Well, good morning and thank you for the opportunity to be presenting to you today. My name is Dr. Gathua Beatrice. I am an internal medicine resident at Moi University, and I also practice at the Moi Teaching and Referral Hospital in Eldoret, Kenya. I will be taking you through the findings of my study titled The Effect of Chemotherapy Education Intervention versus Traditional Care on Knowledge and Self-Care Practices Among Cancer Patients at MTRH. Please take note of the list of abbreviations. GloboCan will be denoted as, of course, GloboCan is, of course, Global Cancer Observatory, while Moi Teaching and Referral Hospital will be denoted as MTRH from now henceforth. So as we know that the burden of cancer has been progressively increasing, and from the GloboCan database in 2020, it has been reported that the number of new cases of cancer is around 19.3 million. This is an increase from the 2017 database of 18 million. In Kenya alone, cancer is the third leading cause of death after cardiovascular diseases and respiratory diseases, with 47,887 new cases reported annually. This, of course, is from 2017 database, but from the latest 2020 GloboCan database, it shows that the numbers are not that low at 42,000. The study has indicated that the incidence in sub-Saharan Africa is set to be to increase by even more than 92% by the year 2040. So because of this increase in cancer patients, there has been also an increase in chemotherapy administration. And there has been a transition for chemotherapy administration from inpatient to outpatient. This is because patients have expressed that it is favorable and it gives more patient satisfaction. It is cost effective to the hospital, and because of the increase in the use of infusion pump, more and more patients prefer out of hospital treatment. So because of these, the cytotoxic effects that we all know of chemotherapy, which are debilitating and sometimes and distressing to patients who are already suffering from cancer, are felt at home. So for this reason, there is an aspect known as self-care. It is not very new. It was first defined by Levin in 1948, whereby he defined self-care as the patient's ability to recognize symptoms, judge their severity, and adopt self-care practices to alleviate these symptoms. So self-care interventions has been cited by WHO as the most promising concept that improves healthcare by providing opportunities for individuals to carry out informed decisions pertaining their health and their healthcare. However, to do this, the quality of chemotherapy education provided by clinicians in low and middle income countries is unstructured, with ineffective, non-standardized approaches to chemotherapy side effects management. This is because most clinicians cite the high workload because of the increasing cancer burden. Of course, there are deficiencies in the healthcare systems, more so in the outpatient setting for most of these public hospitals. And there is poor infrastructure that cuts across most of the hospitals in the low and middle income countries. So for that reason, patients with cancer are also encouraged to take up active roles in the prevention and or management of their chemotherapy-related or disease-related symptoms while at home. This is very good because it helps actually for us to move from clinician structured management of chemotherapy to now involve the patient, so that we can actually focus on their on giving them quality care, and they can be able to be empowered to actually be able to take care of their symptoms while at home. So for this to happen, there has to be streamlined and we have to have streamlined and have measures put in place to ensure patients' information needs are met, and patients are equipped to carry out self-care in order to preserve their self-identity and maintain a sense of normality. Therefore, I set out to determine the effect of standardized chemotherapy education compared to traditional care on patients' knowledge and self-care on expected chemotherapy side effects among ambulatory cancer patients. And the study set out to answer two main questions, and that is one, what is the difference in level of knowledge gained between standardized chemotherapy education compared to a traditional care of ambulatory cancer patients at MTRH? And number two, what is the effect of standardized chemotherapy education compared to traditional care on cancer patient self-care? So in line with these research questions, my study objectives were to assess the effect of a standardized chemotherapy education intervention compared to traditional care or knowledge of chemotherapy side effects among ambulatory cancer patients at MTRH, and also to compare standardized chemotherapy education versus traditional care on patient self-care among ambulatory cancer patients at MTRH. So this, of course, was a parallel arm, open label randomized controlled trial with an allocation ratio of 1:1. The study took place in the oncology unit located in the Chandaria Cancer and Chronic Disease Center at Moi Teaching and Referral Hospital. The target population were the ambulatory chemotherapy naive cancer patients undergoing scheduled to undergo chemotherapy treatment at MTRH oncology unit. So as to help you understand the results, so this is how the study took part. Once we randomized the new cancer patients scheduled to undergo their first chemotherapy cycle, they were put in either intervention or control arm, and that will be at T1, that is pre-first chemotherapy time. The intervention group, of course, received information concerning the standardized chemotherapy education that involve the drug information, chemotherapy side effects, and self-care practices, which involve what to do when you have any side effects while at home. And then, of course, they were followed up for 1 to 4 weeks, depending on the chemotherapy regimen, until the second cycle of chemotherapy. And then the control group just continued with the usual care of management. So when it comes to my results, the study took place between August 2020 and March 2021. The study assessed for study eligibility 482 participants, and 366 participants were randomized into the intervention arm and the control arm. For the final analysis, the study analyzed 179 participants in the intervention arm and 175 participants in the control arm. When it comes to the social demographic characteristics, the study had patients with an age bracket between 18 years and 85 years, with a mean age of 50.3 for both, which was distributed 49.7 in the control arm and 50 in the intervention arm. When it comes to the gender, you can see that we had more female patients in the study than the male, and this is similar to most of the literature review findings. And this was slightly statistically significant. However, when it comes to research on the role that gender plays in how patients experience cancer and its clinical relevance, it is yet to be established. So that was not very something that I could actually report on. When it comes to the occupation, to the residents, of course, most of the participants came in from the regions around Uasin Gishu region and the Western Nyanza area, and most of them were farmers. So the study also recruited patients who are between, who had an equal stage between 0 to 2. So when it comes to my first objective, whereby I was comparing the knowledge between the two arms at T1, just before chemotherapy, and when they came in for the second chemotherapy, that would be at T2, when you check the total score of knowledge, there was a mean score of 5.4 at time 1 for the control arm, while the intervention arm had a baseline score of 5.0. After, when they came in for the second chemotherapy cycle, that will be at T2, the control arm had an increase in the knowledge mean score of from 5.4 to 8.6, while the intervention arm had an increase in the total mean score from 5.0 to 9.7. And this was actually statistically significant. And when we place the difference of the means of the difference of the means in the difference to difference analysis, whereby I mean when you check the mean score at T1 between the intervention and the control, and you check the difference in the mean score at T2, and then you subject this score into difference in different analyses, you actually get a value that is statistically significant, that's less than 0.01. And the best thing about doing a difference in different analyses is that it accounts for changes to factors other than the treatment and the intervention the study is about, meaning that there are no external factors that interfere with the study, with the intervention that was put in place. Things like use of internet, things like information from an external source. And this is very important. It means that the intervention is solely the what affected the increase in the knowledge. So to explain this, knowledge is seen as essential and for empowerment, and this occurs when individuals' capacity to think critically and make informed decisions is supported, and they make decisions about the healthcare. And studies have shown that there is positive outcomes that have been reported on disease-specific knowledge, adherence to medication, and as well as self-efficacy among people with chronic diseases. So when it comes to the second objective, here I was checking the effects of self-care behavior. And when I was assessing the self-care behavior, what helped me is the number of correct actions taken, meaning for each and every side effect, was the patient able to carry out correct action that alleviated the symptoms based on what we taught them or gave the information on. So when you see this box plot, you can see that for the intervention group, they were able to take correct actions on 42.9% of their symptoms, compared to the control group who managed to take only 33.3%. When we subjected this into the Wilcoxon-Ransom test, it showed that the difference between the two medians of 42.9 and 33.3 was actually statistically significant. And this is very important because it means that a patient is able to understand that if I'm experiencing symptoms like I'm vomiting a lot, they are able, once they get the information, they're able to know, okay, I have medications with me, so I can actually take this medication. And if I do not improve, they're able to actually have a way to reach the hospital via telephone calls, where they are guided to seek medical assistance, or they're able to take themselves to the hospital, other than the staying at stopping treatment or not actually progressing with or actually waiting for the symptoms to worsen. And this shows that the patients are actually capable in initiating self-care actions and controlling disease conditions to maximizing their well-being, or choose approaches to approach living conditions to cancer. Therefore, information on self-care strategies should be implemented at the start of chemotherapy, and proper assessment and proper guidelines to be put in place. So I would like to really say that a well-structured and standardized chemotherapy education intervention does increase the level of knowledge on side effects from chemotherapy. And number two, this study has demonstrated that standardized chemotherapy education improves self-care behavior and practices among patients receiving outpatient chemotherapy. So my study strength and limitation is that the strength is that the study was an open-label randomized control trial with good sample size, with diverse type of cancers and different chemotherapy regimen, and the design employed and whereby there was implementation of the written material and technology that was used. That means the follow-up phone calls to enhance recall of self-behavior was actually a pretty good strength for the study. Of course, my limitations include that the study assumed the general adult population literacy level, which is being placed at 81% by UNESCO for 2018. There was no assessment of the literacy done. And then number two, the intervention period was actually short. I would hence was unable to demonstrate cumulative benefits of patients' involvement in self-care practices from the beginning of their first chemotherapy regimen to their last one, whether it's 6 cycles, 12 cycles, or according to their chemotherapy regimen. So I would like to recommend the need for a well-structured and standardized education package on chemotherapy and potential adverse effects to ambulatory chemotherapy naive patients in centers or in areas whereby they administer chemotherapy, and there is no guidelines to actually help the patients be get empowered to actually take care of themselves while they're away from a hospital settings. And number two, I would recommend that studies to assess or cumulative increase in the level of knowledge from beginning of chemotherapy to the end, so that we can also assess the number of dropouts, hospital admissions, and how patients are able to adhere once we empower them to actually take care of themselves and the side effects, so that to reduce the number of actually even like hospital admissions. So I would like to acknowledge my supervisors, that will be Dr. Njiro Evangelim, who's a physician and oncologist, and also part of the She's also part of the senior lecturers in the faculty in School of Medicine, and Dr. Cobra Charles, who is also a physician and a lecturer in the University of Moi University. And these are some of my references. And I'd like to stop there, and thank you so much for the opportunity once again.